Thanks, Carl. Last paper in this session is by Peter Millett. How do you handle the ends?
Thanks, Jerry, and thanks for inviting me to be part of this great symposium. So I'm going to talk about the medial and lateral clavicle fractures. These are my disclosures, none of which are relevant to this talk. Clavicle fractures can be divided into thirds. We've heard about the middle third. I'm going to talk about medial, which are pretty rare, and then spend the majority talking about the lateral thirds, which are a little more common. The medial third clavicle fractures represent about 5% of all clavicle fractures. They're more common in male. They're usually extra-articular and minimally displaced, which means that they can usually be treated non-operatively. It's really important with medial fractures to get a cephalic tilt view so that you can recognize this. I've seen several patients who've had problems here and it's been undiagnosed. CT scans are certainly helpful, and in one study, 22% of the fractures were only seen on the CT scan. The mechanism of injury is usually a high-speed injury, vehicular trauma, motorcycle accidents. I've seen it in football players. You do need to look for associated injuries, rib fractures, pneumothoraces, pulmonary contusions, and head injuries as well. The classification, the Edinburgh classification, can be utilized for these. You see the undisplaced fractures here, either extra-articular or intra-articular, and then the displaced fractures, which can be either extra-articular or intra-articular. The treatment options, conservative treatment in a sling or a figure of 8, whichever is more comfortable for the non-displaced or minimally displaced fractures. And then operative treatment may be considered with plate fixation or some type of pin. It's usually a plate here because there's not a long enough amount of bone for fixation with a pin. One important thing to recognize is medial physeal fractures. The medial clavicle physis closes late between 20 and 25, and this can be a life-threatening injury if it compresses the great vessels, and it can easily be missed as well. And you can see here a right medial physeal injury, and here's a 3D reconstruction of a left physeal injury. So it's just an important thing to recognize in the younger patient with this type of injury. When they are displaced posteriorly, closed reduction can be used for these physeal injuries, followed by a sling and swath. If you're unable to obtain closed reduction, then open reduction, internal fixation is usually preferred. You may be able to just do an open reduction and not have to put any fixation. With these young people, you might be able to sew the periosteum and it'll be stable. So medial clavicle fractures have a low incidence, high energy mechanisms. You need to look for multisystem trauma. Open injuries or associated neurovascular damages are uncommon in this area, and a CT scan is useful to look for these because of the difficulty imaging that area with plain x-rays. Typically we use non-surgical treatment except for open fractures and posterior displaced fractures and floating shoulders or non-unions. This is an x-ray here just to keep our two previous speakers happy. This is a Basmania and this is a McKee over here. So, this is a case example here. A 23-year-old male, lacrosse player, college level, injury 4 months ago, presented with sternoclavicular joint pain. And you can see here he's gone on to develop a non-union of the medial clavicle here. It's extra-articular fracture. There's a small piece of bone here at the SC joint, just a close-up view demonstrating that. So a challenging fracture to fix because you're dealing with such a small fragment of bone here, but if you excise this, this is likely to be unstable because of the principal stabilizer of the costoclavicular ligament here. CT scan was helpful. This patient was bothered by this because it was projecting anterior. You can see how the clavicle is actually pushing his skin out here, and he has a prominence of the bone, some callus formation in that region, but it's gone on to a non-union. So this is how we fix this. You can use some of the small fragment and mini fragment set. We use 90-90 plating in this just to get additional fixation in the distal or in the proximal piece of the fracture, and he went on to successful union. The lateral third fractures are a little bit more common, and the important thing to recognize here is that the coracoclavicular ligaments are in this region, and they play a role in how you address these fractures. These represent about 16 to 30% of all clavicle fractures. They're more common in middle-aged and elderly people, unlike the medial side, which is mostly in younger people. The mechanism is simple fall or direct blow to the shoulder. Again, the classification, these are type 3 fractures. Type 1s would be middle third. Type 3s are the distal. And then there's the extra-articular non-displaced, intra-articular non-displaced, and the displaced fractures here with variations of extra-articular and intra-articular, and also in how they're related to the corticoclavicular ligaments. I think the Neer classification is the most popular way these are looked at. He basically divided the Allman type 2s, which were the lateral third fractures, into differences based on where the fracture was in relation to the corticoclavicular ligaments. This is the Neer type 1, which is lateral to the corticoclavicular ligaments. These are typically stable and can be treated non-operatively. Late excision of the distal segment with a Mumford can be utilized if it goes on to become problematic, and they do have a high union rate because it's in the metaphyseal bone. The type 2s are the most common, or the most commonly associated with problems. They can either be medial to an intact CC ligaments, which would be a 2A as you see here, or between the ligaments as you see here, which would be type 2B. Basically, it ends up like a functional AC dislocation, and they are unstable. They have a higher rate of non-union, malunion, and these are the types of fractures that typically in an active patient we would consider for operative fixation. The type 3s then would be the distal fractures, and these can be either, and these are the type 3s would be distal and into the AC joint. And typically these can be treated non-operatively or acute distal clavicle excision if they are highly comminuted or there's risk of post-traumatic arthritis. Non-operative treatment for these results in up to 33% failure to unite, and sometimes a long delayed course with union. Operative fixation has shown high healing rates in several studies. So the indications for fixation of the lateral fractures, open fractures, multiple fractures with a floating shoulder, neurovascular fractures, or neurovascular injuries, and then those that go on to a non-union. I think late surgery is a reasonable option in elderly patients. You may want to try non-operative treatment first. The displaced fractures of the distal clavicle are usually treated more aggressively. In the elderly, however, non-unions have been shown in some studies to be associated with minimal symptoms and a high degree of patient satisfaction, with few requiring delayed or operative intervention. So not all of these unstable distal clavicles require fixation. So if you decide you have a patient who is a good candidate for fixation, how can you fix this? There's a variety of different techniques which have been described in the literature. Everything from K-wires, plate fixation, external fixation has been described, CC screw as you see here, some type of tension band or suture, transferring the coracoid process to the clavicle is even described, or a hook plate. I think now with modern plates that are designed for this, can be utilized. The hook plates may have a role, though, as we'll go into. There's associated incidents of need to remove these or potential persistent pain, and then there's some other types of fixation which we'll go into. Arthroscopic treatment is an option for some of these. This is a study from France where they used basically cortical fixation buttons and arthroscopic technique with a suture to pull the fragment back down into its anatomical position, and that holds it in place while it heals. So that can be an option. Late surgery for distal clavicle fractures, you can excise the distal clavicle if it's if they have post-traumatic arthritis. That can be done arthroscopically or simple open excision. You may or may not have to reconstruct the CC ligaments if the fracture extends medial to the conoid and trapezoid ligaments, or you can do reduction and fixation of the fracture. We'll go through some case examples of distal clavicle fractures. This is a 28-year-old female, right-handed, fall from a height onto her left shoulder. Here you see extra-articular fracture It's lateral to the corticoclavicular ligaments, is a near type 1. So the CC ligaments are intact, and this is extra-articular, so this is one that it's fine to treat non-operatively, and this went on to successful union. This is a 60-year-old male who had a clavicle fracture of the distal third in 2000. He was treated with a sling, and then he had another injury cycling recently in 2010. Here you can see a fracture. This one's medial to the corticoclavicular ligaments, displaced medial fragment, deformed distal fragment from his prior fracture where he had it fractured through an old malunion. And this is one that we elected to treat surgically with a plate fixation and use local bone graft. Another example, 70-year-old male, fall from a height. He's an active patient, which is important to consider. If he was not active, you could probably consider non-operative treatment. But this fracture was complicated because it was intra-articular distal comminution, which is a near type 2 variant with the both CC ligaments disrupted. And he had a lot of deformity and was bothered by the ptosis of his shoulder. In this case, he underwent a distal clavicle excision and reconstruction of the CC ligaments primarily, and ended up with a reduced fracture here, it reduced AC or distal clavicle and resected AC joint. Another example here, a 55-year-old woman, very petite, and her distal clavicle was fractured in a motor vehicle accident. She also had associated rib fractures. You can see the displacement here. Again, this is medial to the corticoclavicular ligament, so it's an unstable type fracture pattern. Frequently, the conoid and trapezoid ligaments may be attached to this fragment if it's comminuted, or in this case, it was just attached to the distal piece. And this is a case where you can use just simple suture fixation. Because she was small, we were concerned about hardware prominence. Javier Duralde just presented using this type of technique at the closed meeting here, where he had 20 cases and all united. And this was a case I did where we just passed sutures around it. You have to get it underneath the fragment that's attached to the conoid and trapezoid ligaments, and then you can cerclage this piece back in place. And this is what it looks like after it's reduced. What are the results of distal clavicle fractures? Well, they're pretty good. This is a study that was just published in this month's Journal of Shoulder and Elbow Society, just as one example. 38 patients, all treated surgically. Some were treated with hook plates, some were treated with a standard plate. 36 out of 38 went on to union. They had better results and lower complications in those that underwent acute treatment versus delayed. And they used hook plates in some of the delayed group, and they had more problems with this, and recommended against using a hook plate in a delayed situation, but perhaps in an acute situation the results were okay. So in summary, medial clavicle fractures are fairly rare. You can usually manage these non-operatively. The thing you need to look for is posterior displacement, and that will require some type of intervention. And you need to watch for Physeal injuries. Some of the small fragment and mini frags plates that are available now allow you to fix these small fractures. The lateral clavicle fractures, I think the key thing is to look for the location in relation to the corticoclavicular ligaments. If it's distal to the CC ligaments, you're usually able to treat that non-operatively. If it's proximal or in between them, you're going to probably have to do some type of a stabilization procedure, and the displaced type 2 fractures, early fixation is advocated. So, thank you very much.
Thanks, Peter.